So the next speaker for the session is Dr. Vishal Kishore. Dr. Vishal Kishore is a well-known and phaco and cataract surgeon at Mahavir Netralaya Patna and Vision Eye Center, and he has been trained in cataract, medical retina and uvea from Arvind Tirunelveli, and he's a good friend, so I request Dr. Vishal Kishore to give his presentation on anterior fixated IOLs, anterior iris fixated IOLs.
Good morning, everybody. So thank you, Abhishek, for making me the part of this IC. So coming to my talk on anterior fixated iris claw lens. Now, brief history, like it's a third generation IOL and termed as iris supported or iris fixated IOLs. It has some advantages like it is away from angle structure, so the complications like secondary glaucoma is less, there's chance of dislocation is less, and since there's less contact with corneal endothelium, so it's very least likely to cause endothelial decompensation, but it has some complications like iris chafing, pupillary distortion, chronic inflammation, cystoid macular edema, and rarely endothelial decompensation. Now, why this iris was chosen to support the lens? What was the reason behind it? Basically, iris is considered to be toughest tissue within the eye. It is the most resilient tissue, and as it goes with other structure, like any pigmentous structure is tough in nature, same goes with the iris. So with these reasons, it was decided we can try iris for fixating the lens. And apart from this, the pupillary dilatation mechanism helped them to decide where they should fix the iris, so that it leads to minimal distortion of the pupillary area and good view after the Siemens. Even you can have a good fundus examination post iris claw lens implantation. So these, like, what are the mechanism for pupillary dilatation? Basically, pupil we have divided into three concentric area. The central part is the highly mobile and dilatable and constrictible area. Then the paracentral, that is 2/3 from the base, is thickened area, and the base, that is the iris base, is totally immobile. And basically we target this IOL fixation in this area, so that there's mobility of the pupil remains intact. Now, how this iris claw means, how it was discovered, what raised this discovery? In the early model, Jan was sometimes observed that some iris tissue was caught in the slot of the lens, and this clasping of iris tissue proved the possibility for stable fixation of IOL. Then on further tests, they saw that this efficacy of additional fixation method had been proven, and additional iris stitching seemed no longer necessary, and so this iris claw lens came into play. Then came the lens design. It is basically based on iris bridge support. The fixation points of these lenses are located in the virtually immobile part of the peripheral iris, so the iris dilatation is unaffected, and the iris bridges forms are sealed and protects the cornea from touching the PMMA haptics of the IOL. So chance of corneal decompensation is very minimal. Since the start of this original design of the iris claw lens, the fixation concept of this lens has remained unchanged. Even the lens design has slightly changed the term of vaulting and oval aperture. Now this is the first one, is the worst iris claw lens, that is the basic design. And again in 1997 there were some changes where it is called artisan design, and there was vaulting of the lens with oval aperture. Now this iris claw lens causes unrestricted dilatation because the haptics is attached with peripheral virtually immobile iris stroma, and thus allowing the pupil unrestricted ability to dilate and constrict. Even angiography was done, and it has shown no leakage of the iris vessels at the inclination sites, and only few cases of iris trophy in the area of fixation have been reported in the literature. So it is a very safe procedure and a very simple one. This is a video. I'll just play it.
The institute.
Since this lens has been dislocated lens has been removed by pars plana vitrectomy, then we made the entry in the anterior chamber. We constricted the pupil by injecting pilocarpine. Means this we are injecting the pilocarpine. Means we have properly done the vitrectomy from the pars plana area, and after the pupil has constricted, we are injecting the viscoelastic material, and then we insert the lens, iris claw lens. And our target is to, after inserting the lens, we have to rotate the lens so that the haptics lies in the 3 and 9 o'clock position. Now in this procedure, like while inclination, you can either done from the front or from the pars plana. Since we had the pars plana area, so we inserted the dialer from behind from the pars plana area. We held the lens with a forceps and we increments, just push the iris forward from behind and it gets caught on that claw. Similarly, it is repeated on the other side. Same procedure. Means you go from pars plana, push the iris from behind and it gets caught in that claw. And after that, just you do the PI. Simply with the venous you can do, or with the cutter. And then you close the wound. You have to have air so that there is no displacement, no vitreous disturbance. You have to suture the wound. Now this is if you are doing from the pars plana, but if you're doing even like, suppose if you are doing everything all vitrectomy from the anterior approach, then you can do, means you can enclave the iris, this iris claw lens, by holding one of the claw with a forceps and just pushing the other part from behind, or either from the front of the iris claw or from behind with a chopper or dialer, and this will cause inclination of the iris tissue. This is the proper technique. Means fix one claw with the forceps and other you make it mobile with the help of dialer or chopper. This is a wrong technique where you are holding the both single part with the forceps and you are just pushing this with dialer to move up and down. This is the wrong procedure. Then in this there won't be proper inclination of the iris tissue. So chance of displacement is there. This is a chart to show the advantage. I'll just skip this. So coming to contraindications, it is not advised to use in patient having recurrent or chronic iritis, in case with retinal optic nerve defects, corneal dystrophy, severe iris atrophy and uncontrolled chronic glaucoma. It has benefits like iris bridge protects the endothelium, so less chances of endothelial decompensation, safe clearance from vital structures, unrestricted pupillary dilatation and constriction, excellent centration. Thank you.
Yes, please.
Thank you, Dr. Vishal. That was a wonderful presentation. So you are actually saying that it's not always necessary to go through the pars plana.
Yeah, suppose if you are having a patient aphakic, even if you are doing your own surgery and at the end you see like there's no support, and if you can do the vitrectomy from the side port, there's no harm. Since we had a backup and the surgeon preferred pars plana, so we went from the pars plana. But if you are having dislocated IOL lens or any other dislocated IOL, then you have to go for the pars plana. But if you are simple aphakia without any lens or IOL, then you can go from anterior approach also. There's no harm.
So my next,
but you should try from side port, not from the main port. That is important when you're doing this from the anterior approach.
the second instrument should be from the side port.
No, I'm saying when you're doing from the vitrectomy from the anterior approach, then it should be from the side port only.
Okay, okay.
And second means that is your convenience, but conveniently always the dialer or chopper from the side port only. You're holding the one claw with the forceps, that could be done from the main wound, and the other from the side port, either the side port.
Okay, just one quick question because we have 2 more speakers to go. Iris claw lenses are now established.
Yeah.
And you showed all the
Advantages and
disadvantages also in the end. We have a lot of disadvantages with this ICL also.
yes.
My question is, if there's so much of an issue with ICL and iris claw is an established IOL, in high myopes, would you advise iris claw lens instead of ICL?
No, never.
Why?
No, if you are implanting
When
iris
you are putting the same thing in another eye, which is a phakic, in a phakic eye, why you cannot put a...
Why can't you go for the surgery itself? Surgery per se, you can go for phaco.
In high myope, no lenticular issues.
No, but
When we are treating with the ICL
Okay.
of high myopes who
these
cannot undergo LASIK, why can't we use a iris claw lens in those patients?
the reason is whoever you are planning this ICL, they are basically young patient, and this iris claw lens, they have a disadvantage, means they are causing some distortion to this iris. Apart from this, they can even cause secondary glaucoma, though it is rare.
There are so many disadvantages with the ICL
So
also.
you don't try this in young patient. But ICL, you can explain this thing, at least if a patient with a minus 18 or 20, they are undergoing ICL. For some time, they will have very good vision. People will properly center. Their idea is like they have to face the public or for any other purpose. They want to have a like spectacle free and have a better quality of life.
They will be spectacle free with iris claw.
But
anyway,
in
we'll discuss
iris claw,
this.
you'll see this distortion.
Dr. Satyajit,
Can we have your views on this?
The thing is, if we are putting in a high myop patient, so what will be like this? High myopic patient, and as you are saying, they are young patients.
Yeah.
Right. So it's cosmetically not good.
Yeah, cosmetic.
other thing is what you doubt is correct. Johnson & Johnson Vision has an anterior iris claw lens for phakic people, for high myopes and hypermetropes. They have used it and they have a study. What is the problem is they do have, it's a more of a ICL is more of a reversible process. Taking out the IOL is much easier as compared to your anterior iris claw.
I've been made to understand that iris claw removal is also easy.
It's easy,
No, not
but
that
not
easy.
as easy.
It causes
The
iris
newer
sharpening.
iris claw lenses are very easy to take out. Just the way that you click it in, you have to click it out. But
Another thing is that sometimes it can lead to the manipulation which can cause cataract. So like anterior
that even
capsule
ICL can cause cataract.
No, but
ICL cause
the
cataract, that is true.
manipulation is very
If
less.
the-
That is true.
Yes.
True.
If the vault is good, right? If the vault is between 350 microns, so there are no chances of cataract. When
Name-
we are not touching the anterior capsule, so how? So there is a vault in the ICL as well as the phakic eye.
But then the other issues of glaucoma and all still remain, even if the vault is good and there's no issue of cataract.
Now they have holes, right? They have 3 holes. So
I
for the
understood.
aqueous
ICL is
damage-
also established. Iris
Yeah.
fixated claw lens is also established.
Yeah,
Why
both.
cannot the iris claw lens be used in a high myope is my question.
because we are putting all these things behind the iris in the posterior chamber, and
So why couldn't we put the lens above the iris?
because it's cosmetically, if the patient is moving the eye, it's not good. There is always a reflex that something is in the eye. We can also observe that. And-
Cosmetically is okay.
Yeah, okay. Number
But
two-
scientifically,
Number 2, mid peripheral iris, if it is not there, then again there will be a problem. Pupil won't be.
so he said this iris claw lens is fixated right in the periphery.
We can dilate. That is the issue. But there's
But-
the dimpling effect and those slight distortion stays. Theoretically, whatever we say that it is completely dilating, but that dimple effect and those slightly distortion, oval dilatation of the pupil, that stays.
iris shaping will be there.
Yeah, true. True.
Need
we'll
to move
on.
ahead and
Pigmentation.
Over coffee.
Thank you.
Pigmentation, inflammation.
Thank you, Dr.
Whatever,
Vishal.
Just